Good morning.
Good morning.
They've covered everything I was going to say. It's a real pleasure and a privilege to be here, and lovely to be with you. And I want to say a warm good morning to the people who are watching via streaming as well. It's a real privilege for me to be able to speak with you this morning, so thank you. And a huge thanks to Sarah, where have you gone, for inviting me and facilitating my coming and giving me such a warm welcome. And thanks to many people in the room for the warm welcome. And thanks as well to Alex for a warm welcome and inviting me as well. So, why are we here? I think we're here. I'm asking a big question, right? It's not why are you here, this is why are we here? I think our responsibility is to be happy in our lives. You know? And our happiness is fundamentally dependent on the happiness of everybody around us. What affects our happiness? What are the key factors that we know affect our happiness? The number one factor, it turns out from all of the research internationally over the years, the number one factor is our physical and mental health. It might sound tautologist, but it is really important to understand that the ultimate purpose of the work of your work and of our health and care system is to promote the happiness of people in our society, in our countries. And then comes our relationships at home, really hugely important in terms of our happiness. And our relationships at work, the next most important factor, is the next most important factor. And what's, I think, really fascinating about the research is it tells us that our relationship with our supervisor or our leader is about twice as important as our relationships with our colleagues for our happiness, for good or for bad. And when you look at, you do experience sampling of people in society, for an extraordinarily large proportion of people, the worst moment of their previous day was meeting with their supervisor. So this issue of leadership and supervision is hugely important. And after that come things like relationships in the community, income, whether we're employed or unemployed or whatever. So this work that we do is so hugely important. And where are we now in our health and care services? And I want to begin by really acknowledging, from my perspective, that we're probably in the darkest times in the NHS that I've ever seen in my lifetime. It is a really big crisis in our health services, for all of the reasons you'll be only too familiar with. We have shortages of staff, particularly in some specialisms like maternity and accident and emergency. We're competing internationally for staff and to retain staff. We know that the World Health Organization estimates that by 2030, in 5 years' time, there'll be a worldwide shortage of 11 million healthcare workers. And there's already a huge shortage across Europe. So we're in the business of competing for healthcare staff. My son-in-law is just completing GP training, and my daughter's just completed clinical psychology training, and they're going off to New Zealand in August. I'm kind of personally upset, but happy for them, it's their lives. And we know that one of the causes of the problems of retention of staff in the NHS are the very high levels of stress that staff are experiencing. So I haven't seen the staff survey results for Hampshire this year, but for 2023, something like 30% of staff reported being burned out at work, either often or all of the time. 30%. And we know from lots of research evidence that those levels of burnout are associated with staff illness, cardiovascular disease, addictions, alcoholism, cancers, diabetes, depression, even with family breakup. And we know that those levels of burnout are associated with much less safe patient care. For example, doctors who report those levels of burnout at one point in time are between 42 and 62% more likely to make a major medical error in the next month. And we see similar data amongst nurses, for example, working in intensive care. I'm going to cheer you up, by the way. But let's be honest. Let's be honest about where we are. And, you know, Hampshire hospitals, the figure of 30% burnout is around or slightly below the average in the NHS. And we do tend to, you've got the staff survey data being released next week, and we do tend to look at the staff survey data. Are we above average? Are we below average? It's not good enough. We should be comparing ourselves with the best performing comparable trusts. What's the figure for staff reporting being unwell as a result of work stress in the previous year? In Hampshire hospitals in 2023, it was 42%. The best acute and community trust had a figure of around 32%. It's not good, but it's 10% better. And we should be going to those organisations and saying, what have you done to achieve it? What can we learn from you? How can we implement this within our organisation? There are lots of light spots within Hampshire hospitals. We've just heard from, is it Kerry and Melissa, about light spots. Let's go to the light spots and learn from them. Let's go to the trusts that are doing so much better in terms of levels of burnout and stress. What did you do? How did you achieve? Let's go abroad and learn from the organisations abroad that are achieving really good outcomes. We also, as you know, have an ageing population, so there are increasing demands on services. We have huge problems of inequity and lack of inclusion in our society and in our health service. Whether it's the impact of racism on healthcare outcomes or classism. You know, we know that women from black and minority ethnic groups are 4 times more likely to die in and around childbirth compared with the white majority. That's just horrific. We know, if you take Scotland, probably the worst performing country in Europe in terms of health outcomes. If you take the richest and poorest areas of Scotland, on average life expectancy in the richest areas of Scotland for men is around 72, 73 years of age. In the poorest areas of Scotland, on average, it's 48 years of age. Those levels of inequality are not a basis for a cohesive, fair, happy society. And we have to address those inequalities. And the inequalities that you talked about as well, Alex, within our services. We're making progress, but it's painfully slow. We have to transform. And, you know, given the kind of challenges that we know exist for us in healthcare, the future has to be not about just kind of twiddling the dials. We have to radically transform our healthcare services. We can't go on like this, watching stress levels rise amongst our staff. I mean, it's just paradoxical and wrong. We have the largest workforce in the whole of industry in the NHS, charged with promoting the health and well-being of the people of our country. And yet in the process, we're damaging the health and well-being of a huge proportion of the largest workforce in the country. It can't be right. So whatever we're doing at the minute, we have to transform radically to achieve much better outcomes. And it's that radical transformation that I want to talk about with you this morning to address these issues. And I think it's also important to say that, you know, we talk a lot about leadership, culture, and team working, and lots gets written about it. Let's use the evidence. Let's go with the evidence. Healthcare is an evidence-based practice for good reason. Let's use the evidence that tells us how we can transform our health services. And, you know, we've both mentioned the staff survey, Alex and I, already, that's coming out next week. Do you know it is the largest, longest-running annual staff survey anywhere in the world? in any sector. This is what we have in the NHS. It was 2003 we initiated it, and it's run every year since 2003. So we've got, 21 years now of data from over 650,000 people every year completing it. Can you imagine the wealth of data? And last year I spent some time just kind of distilling and synthesizing what we've learned from the data from the NHS service. And I just want to, from the NHS staff survey, and I want to share with you some of the highlights that have come out from that distillation. What of all of the analysis by academics and policymakers and leaders, what has it told us are the key factors that make a difference? And by the way, we don't collect any data in the NHS which comes close to the staff survey data in telling us how Hampshire hospitals will be performing in 2 years' time. You want to know how a trust is going to be performing in 2 years' time? Look at the staff survey data. We could have predicted mid-staffs from the staff survey data 2 years before. It was a diary of a death foretold. So what do we learn? We learn that the most important factor won't be a surprise to you, predicting the performance of trusts as a lead indicator of the subsequent performance of trusts is the levels of staff engagement. And when you look at all of the outcomes that the level of staff engagement predicts, you would think, wow, this is a lever that we really have to pull. And I know you've been doing a lot of work, Sarah and colleagues, around how we promote staff engagement. What may be a surprise to you to learn is that the most important element of staff engagement that predicts performance is the extent of the involvement of staff in decision making. That's the key factor. And that, I think, is deeply ironic, because if you look at the cultures of NHS organisations in England, this is probably the most hierarchical, command and control, target-driven culture of any part of industry in England. We have the largest, most skilled and most motivated workforce, yet we tend to manage through command and control and target setting. And again, it's ironic because we know from looking internationally that about the worst form of culture for healthcare services is target-driven command and control cultures. That's what the evidence tells us. So we have to transform that. We also know from the staff survey data that we can dig down and say, okay, well, if staff engagement is so important, what does the staff survey tell us about the factors that predict staff engagement? And we can unpack that. And the most important factor by far is the extent to which leaders are compassionate and supportive. And I'll talk more about what I mean by compassionate leadership. This is what the evidence tells us. So this is where if we really want to transform, this is where our focus has to be. And then it's things that you would perhaps expect, working in an appreciative environment that Gary talked about, where people say thank you. There are celebrations of achievement and accomplishment, where we have flat hierarchies, where we've got good team working. And I'm going to come back again and again to this topic of team working, because I think it's something we absolutely don't get right within our health services, and it's a quick win if we can get it right. And you've already heard from Melissa and Kerry about the importance of team working, and from Alex about the power of teams. What else emerges from the data? Well, if you look at patient satisfaction, then we're able to identify from the survey what in staff experience is the key predictor of patient satisfaction over time. And the factor that emerges is staff reports of workload. So the more staff report that they have high levels of workload, the less satisfied patients are. Makes sense, doesn't it? We're under such pressure we can't provide the quality of care that patients want. And the second most important factor is the extent to which there are cultures of equity and inclusion. So the more that staff report cultures of equity and inclusion, the more satisfied patients are. And we're able to, again, tease out why that is so. So we did a very big study where we looked at the diversity of frontline staff in hospitals and the extent to which that diversity mirrored the diversity of the local population using census data. And what we found was that the more there was a good match between the diversity of frontline staff and the diversity of the local population, the better was care quality and the better was the financial performance of these organizations. And by digging a little deeper, we were able to understand what the explanatory factor was. And it is that where there is a good match, patients are treated with greater compassion and civility. And we know that has a huge impact on healthcare outcomes in terms of care quality, readmission rates, and so on. So what's the lesson we take from this? Well, the wrong lesson to take is, okay, so what we need to do is make sure that the diversity of our frontline staff matches the diversity of the patients that we're serving. No, that's not the conclusion. The deeper conclusion, the more powerful conclusion is we have to ensure that all our staff understand that they must treat patients and each other with compassion and civility, particularly when those patients or staff are somehow other than us. We have to be vigilant about being compassionate and kind. I can't see where you are now, Kerry. Compassionate and kind, especially to people who may be somehow different from us. So it's about a way of being, not simply a leadership or a professional skill. It's a way of being. And I do think, that the NHS should be a model for the rest of society in terms of how we manage diversity. We should be presenting a wonderful model for the rest of society to emulate. We're the anchor institution for the nation. We're the biggest employer. Everybody uses our services throughout their lives. We should be a model. We should be striving to get this absolutely right. And Alex, you've already talked about leadership representativeness. We know, for example, that the more leaders are representative of those they lead, the less bullying and harassment and discrimination there is for all staff. It has a pervasive effect. And I mentioned a little bit about team working. It's astonishing just how powerful the extent of team working is as a predictor of trust outcomes. And you can see here some of the outcomes. When people work in real teams in our NHS, and I'll say what that means in a moment, stress levels are 50% lower. That's a big win, 50% lower stress levels. Much higher levels of innovation when people work in real teams. Interestingly, people also stick within agreed protocols much more when they work in teams. So there's more innovation but within safe boundaries. We also see dramatically lower levels of avoidable patient mortality the more people work in real teams within NHS organisations. Real team working, what does this mean? Well, quite simply this, we ask people in the staff survey, do you work in a team? Well, over 90% of people say, yes, I work in a team. And then we say, does your team have clear shared goals? Basis of team working, isn't it? How can you be a team if you don't know what you're doing together? And secondly, do you meet regularly to review your performance and how it can be improved? Just those two questions. And then the figure drops to 40%. So we know that around 50 to 60% of people in the NHS are working in what we would call pseudo-teams. And the more people who work in pseudo-teams, the higher, dramatically higher the levels of stress, there are more errors, there's less innovation, patient satisfaction is lower, there's violence against staff, and there are much higher levels of avoidable patient mortality. So the quality of team working is really critical to creating these outcomes. That's me in the middle, and I've talked about burnout and workload already, and how that has such a dramatic impact. So the point I want to make is, we have the evidence about what works. These things don't cost a lot. They don't cost a lot of money. They're the factors that make most difference from all of the data to the performance of our organisation. So rather than politicians and corporate leaders at the centre of the NHS banging the table around targets, this is what they should be focused on. How we ensure better well-being in staff, more involvement in decision-making, better team working, more inclusion and valuing of diversity. And I hope that in the next couple of weeks, the King's Fund will publish a blog summarising what we found and bring this to the attention of key leaders. So the priorities, I think, for us in how we think about the future of leadership are these. Making workforce the priority, and compassionate leadership has to be at the heart of that. And making that happen in practice, not just as a kind of aspiration. Address issues of equity, valuing diversity and inclusion, addressing how we meet the core needs of staff. So this is not about just giving you more access to mindfulness apps or advice on diet or exercise. This is addressing the fundamental problem that the reason that staff stress is high and has been rising is because we're not meeting the core human needs of those who work in our organizations. So we need to understand what those are and how we meet them. I'm not arguing against access to mindfulness apps and advice on diet and exercise. I'm just saying, yeah, that's fine, but it's not addressing the core issue. We have to address the core underlying issue. And we have to move away from these hierarchical cultures which prevent innovation. I was talking recently to a consultant in A&E who said, I make multiple life and death decisions every day, very complex decisions. And recently we needed some new clipboards for the department. We just desperately needed them. £70. I put in a request, it went through 7 different people in the finance department. Sorry, Melissa. Where are you? It went through 7 different people in the finance before they turned it down. Now, you know, we giggle and we laugh. This man was so profoundly upset. I'm on the verge of quitting the NHS. He's been rescued by, been inculcated into a leadership program to give him a new hope. Hierarchy, command and control suppresses innovation. It prevents the development of ideas from new and improved ways of doing things and then implementing them in practice. Because what happens is people give up. There's no point. I've tried to change, there's no point. It's called learned helplessness. It's the opposite of learned optimism. So we have to learn about how we can create an empowered organization where people can really influence the decisions, can implement innovation, can bring about change. And that's about building team-based working and getting rid of hierarchy. I was in a hospital in Denmark 3 weeks ago. 3 levels of hierarchy. There was the leadership team, which was actually only 4 people, and then a layer of 40 managers, and then a frontline self-managing team. So that was it. The Berkshire organization in the Netherlands, a community care organization, has 10,000 staff working in community health. There's 10,000 people working in self-managing teams. That's it. There's no leadership. There's a central team that provides team coaching support, HR support. We can do this. We can do this. There are good examples of where we can achieve this. Tyne Escondria has cut its number of bands from 7 to 3, I think, at least a couple of years ago. So, yeah, the beginning and end of all of this, I think, is compassion. And I want to show you a video that my colleagues in Wales have made that I think is a good kind of, it's a great way of communicating what we mean by compassion. Just go up. think about it. It is interesting, you know, that what we know about human behaviour is that there are 3 degrees of separation. So when, I don't know, the example you gave, Alex, of who was standing at the front door?
We all take a turn.
You all take a turn, and you say good morning and welcome people. And we know that compassion or irritability or unkindness has something like 3 degrees of separation. So, you know, if you behave compassionately to me, then I go on to replicate that in a number of subsequent interactions. Those people go on to replicate again in a number of interactions, and those people go on to replicate again. So the effects of our behaviours they ripple out an extraordinarily long way, affecting tens or hundreds of subsequent interactions. So the decisions we make about how we behave are hugely important in shaping the culture of our organisations. And I just want to go back to that hope in the dark idea. I've described the challenging environment we currently face in health services. And, you know, in the wider world, it feels very uncertain and frightening at the moment. And to pick up on the quote that you used, Alex, from Margaret Mead, that title, Hope in the Dark, comes from a book that I read a couple of years ago by Rebecca Solnit. She's an American philosopher and feminist, amazing person. And in the book, she argues that in dark times, hope doesn't come from some starry-eyed optimism. It comes from us taking collective action together to make a difference. And through compassion, we can make a profound difference. We're living in a world at the moment that feels characterized by threat and greed. And compassion is the antidote to that. So we can all take personal responsibility for how we live to create more compassion rather than threatening, greedy kinds of cultures. So what is this word? What does it mean? Let's really understand it. And Paul Gilbert, who I think is the guru of compassion in this country, defines it in the way that you see there. So just notice that it's about how we are to ourselves as well as how we are to others. You can think about for yourself, how good am I at being compassionate to other people? I imagine that virtually everybody in this room will say, yeah, pretty good. How good are we at receiving compassion from people? How good are we at being compassionate towards ourselves? Another way of understanding compassion is, and I think the practical way, is that it has 4 key behaviours. So if my wonderful friend Agnes here is in pain or distress or is upset, then for me to be compassionate towards you, Agnes, I have to do 4 things. I have to attend, understand, empathise, and help. Attending, understanding, empathizing, and helping. So attending means, first and foremost, I have to be present with you. So in the here and now, not thinking about how can I be compassionate towards Agnes, or how long is this going to take, I've got a meeting to get to, or what's just happened in that last meeting. It's letting go of all of that and being present. So let's just explore that a little bit, because we don't have to try to be present. We're always present, aren't we? By definition, we're always present. It's just that all of this stuff goes on in our heads that gets in the way. So it's about letting go of all of that. So if you imagine a fist, I'm holding my fist tightly. Being present, if you like, the analogy is letting go. Okay, I can let go of everything else and just be present here and now with you. And what that enables me to do also is attend in the sense of giving my emotional and cognitive attention. And as Alex mentioned earlier, there's a wonderful phrase that's not mine. It's Nancy Klein talks about listening with fascination. So when we're truly present with the other, we can let go and just listen with fascination. And that's the basis of compassion. That's the powerful platform, if you like, for compassion. Because what that then enables us to do is to understand. I can then understand the causes of your pain or distress, ideally through us having a dialogue together, Magnus. And that in turn enables me to empathize. I have a good understanding. I can then feel your pain or distress. But having the presence not to turn it into my drama. So yeah, oh, that must be really difficult. Yeah, that must be really painful. I can understand that. So we are hardwired, or virtually all of us, with billions of mirror neurons that enable us to feel others' emotions. And so what empathizing then enables us to do, and what gives us the motivation for the fourth critical element of compassion, which is the intention to help you or serve you in some way. How can I help? How can I help? And we know from neuroscience studies over the last, thank you, we know from neuroscience studies over the last 20 years that there's a fundamental difference between empathy alone and compassion without an intention to help component. So when we ask people to be empathic in neuroscience studies, to someone in pain or distress, that's associated with the activation of various pain centers in the brain, the relevant pain or fear center, whatever it is. But when we ask people to be compassionate, that activates the reward center in the brain. Why? Well, because we've been hardwired by evolution to be compassionate to others in pain or distress, 99% of the time. It makes sense in evolutionary terms. You know, we help others in pain or distress. It enables us to form families, communities, tribes, etc. Compassion is about blurring the boundaries between self and other. It establishes a feeling of trust or connection, belonging. And belonging is fundamental in human behavior. Did you know that you are as likely to die from loneliness as you are from the effects of smoking 15 cigarettes a day? And it's really concerning because we're seeing a really huge increase in levels of loneliness in society. In the last 10 years, 30% more people across Europe are living alone. In the United States of America, the majority of men have no close male friends. There's been a huge shift over the last 25 years. And interestingly, when people are lonely, they're much more susceptible to populist politics. So compassion is an antidote to loneliness, if you like. That increasing loneliness we see people more and more. I was on the tube in London this morning coming here and just seeing everyone sat there just alone in crowds. And we also know a lot more now about the role of compassion in healthcare. And what the research, thousands of randomized controlled trials and meta-analyses show us is that compassion is the single most powerful intervention we have available in healthcare. So I'll show you a few quick examples. By the way, I neglected to say, which I apologize, that please stop me if you've got questions. So I will pause and see if you have questions. But at any point, if you have questions or comments, please do say, raise your hand. So here's a few select examples. The first is a large randomized controlled trial of anaesthetists visiting patients prior to surgery, where in one arm of the study they do a normal visit and provide sedatives. In the other arm, they do a normal visit, don't provide sedatives, but are briefed to be extra compassionate in how they interact with patients. And that's associated with patients having a much lower requirement for painkillers post-surgery. And they have a significantly shorter length of hospital stay. The second example is a very famous large randomized controlled trial conducted in Italy and North America of patients with an early diagnosis of non-small cell lung cancer. It was a study of quality of life, and in one arm of the study, patients had normal early cancer care. In the other, they had normal early cancer care plus early palliative care. So if you like, an extra dose of compassion early on. And that was associated with a much better quality of life, not surprisingly. But what was an unexpected finding was that those patients also lived significantly longer. And we see similar large effects of clinician compassion in the treatment of long-term disorders like HIV and diabetes, and of therapist compassion in the treatment of mental health problems. And I think what's really remarkable and consistent with what I was saying about the neuroscience studies, in randomized controlled trials with GPs and nurses who are briefed to be extra compassionate in their interactions with patients over a 2-week period, that has a significant impact on their own mental health, with lower levels of anxiety, stress, and depression. So the point is, when we're compassionate to another person, we know it benefits them, but it also benefits us. The idea of compassion fatigue it's a misnomer. There's no data that suggesting that compassion tires us out. What tires us out is chronic work overload and empathy fatigue, where we're not able to make a difference. So it's important not to mix those things up. And there are huge cost benefits, we know, from compassion as well. Not surprisingly, to providing better quality care, there are going to be financial benefits. I'm not going to go through all of these, but suffice to say that compassion is the most important intervention we have available to us in healthcare. By the way, I think it's wonderful that one of the values of Hampshire Hospital is compassion. What's really important about culture is how we put values into practice. So the challenge for us is, how do we create the conditions within Hampshire hospitals where staff will be even more compassionate to patients, where they'll be even more compassionate to each other, and where they'll be even more self-compassionate. I'll come back to why that's so hugely important in a little while. And the answer to that question is, well, that's about the culture of the organisation. How do we shape the culture of Hampshire hospitals? Every interaction that every one of us has every day, as I kind of implied, is an opportunity to shape the culture through how warm, irritable, kind, cynical, caring, humorous we are. The emotional and behavioural ripples radiate out. So every interaction is an opportunity for each one of us to shape the culture, not only of Hampshire hospitals, but of our societies and our communities as well. But we know that the role of leaders, and when we look at the last 100 years of research on organizational culture internationally, what it tells us is that the role of leaders is particularly powerful. Because what leaders pay attention to and talk about and focus on and monitor, and particularly what they model in their behavior, tells us what it is that they value. So whatever it says on the website about the values of the organization, what we really read is the behavior of our leaders. If, in many NHS trusts I go to, they have a lovely vision and a lovely set of values on the website, but what staff tell you is that all their leaders are talking about is financial performance and productivity, not high quality, continually improving compassionate care, not providing the best care for every patient that we serve. So it is values are not what we write on the website necessarily. It's it's what our leaders emphasize. So if we're to create more compassionate cultures, then leaders must embody compassion in their leadership. And in practice, what that means is leaders, as Alex was saying earlier, who have the courage to be present with staff and to listen with fascination. We don't have enough qualified midwives in maternity at the minute to provide safe care for women and their families. It takes courage to be present and listen to that. Leaders who have the courage to understand the challenges that those they lead face, not through imposing understanding from some elevated hierarchical position, but through having a dialogue, which may be a very uncomfortable dialogue. And leaders who empathize, have the courage to empathize with those they lead, to feel what it's like to be a nurse on your third 13-hour night shift in a row, where you haven't had time to take your rest break, where for a large part of the shift you were desperate to go to the toilet, but you couldn't get away just to go to the toilet. where you feel bad because you didn't spend sufficient time with that elderly lady who was in distress, and where you now got to drive home and you're feeling exhausted and you're afraid you're going to have an accident. And leaders who have the courage to help those they lead. And that, in this context of leadership, helping leaders, helping those we lead to do their jobs more effectively, by helping to remove the obstacles that are getting in the way, and by helping to ensure they've got the resources they need to do their jobs effectively. The right numbers of staff, the right technology, the right training, and so on. And this, I'm not describing to you here some amazing new model of leadership. No, we've known for 60 or 70 years that these 4 behaviors are critical to effective leadership. The most important skill of a leader is listening to those that we lead. And the most important task of a leader is helping those we lead to do their jobs more effectively, by helping to remove obstacles and helping them to ensure they've got the resources they need. And as I've indicated, we have a wealth of data telling us that, you know, the more people who in a trust who report that their leaders behave in these 4 ways, the higher the levels of staff engagement, patient satisfaction, care quality, financial performance. The more people in a trust who say their leaders don't behave in these 4 ways, subsequently in those organizations what we see is staff reporting chronic work overload, patients say they're not treated with the dignity and respect and care and compassion that they wish for. Care quality is worse, financial performance is worse, unavoidable patient mortality is significantly higher. So for all of these reasons, we have to ensure that the future is shaped by compassionate leadership, by all of us. And you know, when I talk about leadership in NHS organisations, I believe we're talking about every individual within the trust, because patient safety and care quality is everyone's responsibility. We all have a responsibility to show leadership in ensuring high levels of patient safety and care quality and looking after each other. Any questions so far? Please.
I think when you describe compassionate leadership, there is a risk that sounds like someone who's really perfect. You know, you don't make a mistake, but actually, in your book, a lot of your research, you draw that line with humble leadership as well. So I wonder if you might kind of talk us a little bit more about that, about the fact that as a compassionate leader, you also have to admit that you don't know all the answers and work with those to empower rather than sometimes it sounds like it's you have to be perfect.
What's your name? Claire. Thanks, Claire. Yeah, so we know that from all of the leadership research that humility is a hugely important characteristic of effective leadership. And that humility is about acknowledging, I don't know. I don't know what to do. What do you think? It's also the humility to seek feedback from those you lead. How am I doing as a leader? What do I do that is unhelpful? What do I do that is helpful that I could do more of? Yeah, leadership is fundamentally about humility, about I don't know. I don't know what to do in this situation. And in fact, interestingly, you know, I've talked a little bit about team working. Healthcare is done by teams, not by individuals, but we manage our services. We manage individuals. We do all of these individual appraisals across our organisations. By the way, 70–80% of them really appear to be useless. So we have the conversation. Anyway, I can come back to that. No, the data is really clear from the staff survey that staff find these conversations on the whole not to be very helpful. I don't know why we're not doing team appraisals instead. We should be appraising teams on their performance. And I believe we should be training leaders to lead teams. So that's what healthcare is about delivering care through teamwork. But we are so focused on leadership being about leading individuals but we don't train people adequately to lead teams, and it's not difficult. And the key to leading a team is to empowering the team. So we know from the latest research on teamwork, and it reinforces what we've known for years, is that when team leaders empower their teams to make decisions and innovate, those teams are much more effective. And what we know is that shared leadership in teams characterizes effective teams. So you may be the team leader, Claire, but when the colleague sitting next to you has the relevant expertise to the task in hand, the leadership seamlessly shifts. So humility in leadership is about recognizing I don't have all the answers. It's about enabling everybody else to make their contributions. That's what team working is about. One of the things we have to train team leaders to do consistently is shut up. Shut up. So team leader can come to the meeting and say, here's the problem we have. This is what I think we should do about it. No, 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 no. This is the problem we have. Let's hear what people think we should do. Team leader should speak last. For me, that's an illustration of the kind of humility we're talking about.
Michael, hi, my name is Zena. I'm the ops
Your name is?
Zena.
Zena, hi.
Hi, thank you. One of the things that we're all struggling with at the moment is the overworked, the workload, the pressure to deliver more with less. Yeah. And I personally find that as an ops director the hardest bit to lead my team with and support them with. So we all do more because we care, but there's a real burden of burnout, as you already said. And I'm just interested in any other strategies. You know, we do all the clever things, you know, work smarter and divvy up more and see what we can stop doing. The net result is still that we all do much more than we can. And I'm really worried about that on a personal level for my team, but also for our organizations. I'm just interested in any magic that you can offer me.
So I think, Zena, it's a huge issue for leaders, for everybody in the NHS. Work overload is the #1 factor in staff stress, and aside from retirement, the #1 reason why it's in the NHS. And we talked earlier a little bit about moral distress. You mentioned it, I think, Alex. The moral distress of staff who feel they haven't been able to deliver the quality of care they wanted to. But I also see moral distress amongst leaders. So leaders like you who go home at night feeling upset because I know my staff happen to cope with a ridiculous work overload situation. And I feel bad because I, as a leader, I'm not doing anything about it. You know, I'm kind of acknowledging it, but I'm not making a difference. And so I see a lot of leaders who are experiencing that moral distress, which can result ultimately in burnout, stress, and so on. And I think the problem is, as leaders, we're often reluctant to talk about work overload because we don't have the solutions. And that's a mistake because, you know, to take Claire's point, the role of leaders is not necessarily to have solutions to problems, but it is the role of leaders to bring everyone's collective attention to bear on the most difficult issues we face. So, for example, I think in board meetings and executive team meetings, the workload of staff should be regularly on the agenda. It's the #1 factor in staff stress and #2 in retention. So it should be on the agenda. We should be addressing that. And when we have departmental and team meetings, that should be an agenda issue that we come together to talk about. And there are a variety of maybe strategies. We know that if you improve team working, that improves people's experience of workload as well. There are places like East London Foundation Trust, which regularly asks its staff, what would you reduce or get rid of? And they've eliminated, I think it's 85% of clinical audit activities. They're rated outstanding by CQC. I know another of their initiatives was to ask staff, what rules would you get rid of? And I think something like 35% of the rules that people came up with turned out not to be rules at all. But everyone, it had just become a kind of collective myth that this was the rule. They got rid of lots of unnecessary having to ask managers for permission, lots of unnecessary travel to trust headquarters, lots of unnecessary meetings. I mean, the amount of time we spend in meetings that are not productive. Did this really add value? Did I really need to be here? Did it need to be an hour? We've got videotapes of healthcare team meetings that we've amassed over the years, and you see people sitting in these meetings and they're looking down at the floor, and there's a little speech bubble coming out. I hope death comes soon. The point I want to make, Zena, is we need to talk about, we need to talk about this issue collectively and begin to find some of the solutions. And we need to talk about it at every level. NHS England, politicians, ICBs, so that we are addressing that most important issue that is threatening the integrity of our healthcare services. So I hope that this little conversation has helped to indicate also that this is not some soft cushion, scented candles approach to leadership we're talking about here. I think it takes much more courage to lead compassionately than the rather easy opt-out of command and control leadership. Compassionate leadership, because compassion is about leaning towards pain. It's not about pulling away and avoiding pain and difficulty. It's about leaning into it. So compassion is about dealing with difficult behaviours within our teams, our organisations. We talked already about the importance of creating an appreciative environment. I'm sure everybody in the room is really good at saying thank you to those that we lead. Actually, from all of the evidence we have, you can do it 10 times more, as long as it's done authentically and thoughtfully. We can do it 10 times more to create an appreciative environment. But we also need to be able to give negative feedback. People want negative feedback. People want to learn what they can do to improve. So it's having the courage to give negative feedback. Some of the most difficult behaviours in organisations, pretty much every trust I've visited over the last 40 years, there's been one or two people, often quite senior people, who behave aggressively, rudely, dismissively, and who people are afraid of. And often they've been promoted, because people are afraid of them, so they end up being promoted. And, and often part of the problem is no one's ever given them any feedback to say how damaging, upsetting, disruptive their behaviour is. So we have to have, as compassionate leadership is about leaning in and dealing with those behaviours, giving clear feedback, coaching people, and sometimes having to go through formal processes. And there are compassionate ways of doing this. Mersey Care has introduced its restorative culture, where when an error is made, they ask the question, who are all of the people who've been hurt by this error? Maybe a patient, families, maybe the team, maybe the individual themselves. What are their needs, and who's responsible then for meeting those needs? They've eliminated 85% of disciplinary processes and 95% of suspensions, saving millions in the process. And Iron Bevan in South Wales has taken a whole new approach to dealing with employee investigations. They found that those investigations were damaging, it was creating a huge amount of avoidable staff harm. So people who were involved in investigations were still exhibiting post-traumatic stress symptoms at least 14 months after the investigations had ended. And what they've discovered is that they can deal with these problems much further upstream and more informally. And they've reduced the number of investigations by 2/3. Circumstances has gone down by over 1/3, I think, within the organisation, and again, saving millions in the process. We can do this. We can do this. We can operate in very different ways. And it's about dealing with conflicts within our organisations. So I just want to take a little diversion for a minute to talk about conflict. This is one of many books you can get on conflict. This one is by Amy Gallo. It's a Harvard Business Review book. What's the key elements have disappeared. On the journey between Sheffield and Basingstoke. I like this book. It's quite thin. It's got big writing, so I can manage it. Amy Gallo, like many people, distinguishes between task conflict and interpersonal conflict. So we know, there's always going to be interpersonal conflict. In my family, we had little fallouts from time to time, and people talk about it, make up, and we move on, and we're stronger and more loving as a consequence. That's not what I'm talking about. I'm talking about the chronic interpersonal conflicts in teams, where you've got, one person or two people who are continually aggressive, cynical, rude, and that is profoundly damaging to team effectiveness. If it is a patient-facing team, a clinical team, that is as dangerous to patient care as medication errors or dirty equipment. So if we tolerate those behaviours in our teams as leaders, then we're tolerating a significant threat to patient safety. And we have to, I think, deal with it on that basis. If we're having debates or disagreements about what we should be doing, how we should be doing it, and who's responsible for doing it, that's great. Because if we're not doing that, then quality is not improving. If we're not having debates about what we should be doing, how we should be doing it, and who's responsible, then quality is not improving. And if it's not improving, it's getting worse. It doesn't stay static. It's either improving or it's going backwards. So we need to encourage debates about the task in a climate of respect, mutual respect, curiosity, supportiveness. It should be fun. We should be having creative discussions that help us to manage conflicts effectively, because those debates lead to creativity and innovation. If you're not having disagreements, you're not innovating. If you're not having disagreements about what we're doing and how we should be doing it, we're not innovating. So we should be welcoming those debates, but creating a climate within which we can have transparent, constructive, mutually respectful disagreements. And coaching people to do that. So compassionate leadership is about being courageous and about being wise in combination. If you're managing upwards, if it's your leader who's the problem, then you have to be wise as well as courageous. If you see somebody who's fallen in the river screaming for help, and you bravely throw off your coat and jump in towards the river, and suddenly remember that you can't swim either, you're really in trouble. So compassion is about courage and wisdom. When we're managing upwards, for example, if you have a difficult leader, if you do that on your own, you could very well be chewed up and spat out by the system. So we need to work collectively. As Alex was saying, the power of a small group of people working together can make a profound difference. And it's having the courage to work together to address some of those issues when we're managing upwards. That's really important. So, any questions before I ask you to reflect, please?
It's more of a
What's your name?
comment, Lucy.
Lucy, hi.
It's more of a comment, thinking about sort of compassionate leadership. It resonated with me from neurodiversity. So I've got a neurodiverse child, and he sees things very differently, and he would blow your candle out to make his burn brighter. So I'm just sort of thinking, it might be that some people that we work with have similar sort of struggles. Maybe there might need to be a support network in place to sort of help facilitate those leaders. So it's just thinking about neurodiversity and how people process things differently.
Yeah, and part of, and I'll talk a little bit about this, but part of what we need to do is to create an environment where we're valuing that diverse range of behaviours. And I talked deliberately about compassionate leadership as a collective, not about necessarily what we as but that there's an individual approach. And people with neurodiverse experience bring particular qualities to compassionate leadership, which are really hugely valuable and important. So it's how we enable all of that within an inclusive culture. And I also think we're just still in the process of learning about neurodiversity and how we can embrace that within our organizations and within our leadership. So it's a really important and exciting journey. Thanks, Lucy.
My name is Henrietta. As regards to conflict resolution you just talked about, I want to ask a question. For instance, you have something ongoing among your team or departments, and you are courageous enough to pick this out and want to get the team or other persons to help look into it. But everyone seems not to be interested. Maybe reason being that despite everything being done, or maybe something previously have happened and not reserved, despite meetings or anything, nothing good is going to come out from it, despite your input or anything. So everybody lose the interest of getting involved. And yet this thing is staring at your face, and you know that
This thing is what? Sorry?
staring at your face,
Yeah.
and you know that getting this sorted will go a long way to bring progress in the unit and generally. In such situation where you are like just the man standing and you know that you can't do it alone, what's the way forward?
Don't do it alone.
And if anyone is not ready to do it, because some persons like most people have lost interest, like you said, about doing things because they just come like, I just want to work and go home. That's what some persons are all about, just come to work and go home. And you feel like, are you just a different one who don't just want to work and go home? You want to make an impact, you want to create a change. But like you said, a tree does not make a forest, you can't do it on your own. And it makes you look like you are crazy or you're the only one seeing things from this point of view. So I think I really need a little light on what to do in such instances. Do you go ahead and meet the appropriate authorities to say, this is what I think, or what's the way forward to such situations?
Yeah. I think it's really important, as I say, it's really important not to do these things alone, because you can be stereotyped as somebody who's out there, some extreme, or somebody who is making trouble, or somebody who is not seeing the situation correctly. That's what we tend to do with people who have a kind of minority or different view. And they often get, as I said, chewed up and spat out. So it is really important to, first of all, find allies who share your perception of the problems in the team, and that you work collectively. There's a whole area of wonderful research called minority influence theory. And basically what it tells us is when you're in a situation where your view is in the minority, it's very easy to dismiss you. So don't need to pay attention to that. But when there are 2 or 3 people who are repeatedly putting across the same message, but then it becomes much more difficult to resist. It's a bit like, Alex's film, where as soon as you have 1 follower or 2 followers, then the dynamic starts to change. So it's important to find allies who share your concerns. And what you need to do is to, in a way, be clear about what it is you want to achieve for the team. We want to create a team where people feel really good, where we're delivering high quality care, where people feel safe to speak up. That's what we want to achieve. And be clear about the messages you want to get across. 3 or 4 key messages you want to get across. And then collectively we need to raise that again and again and again. Saying it once doesn't work. You have to keep dripping and dripping and dripping. And that starts to cause people to think more creatively. At another level, if that strategy is either too difficult or too perilous or isn't working, I think there's something we need to do in the organisation as a whole, where we are monitoring departments and teams on a regular basis. For example, Northumbria, which is probably, I would say, Northumbria Healthcare Trust has probably been the outstanding performer over the last 10, 12 years, I would say, amongst acute trusts. Would you say, Alex? Yeah. And what they do is they do pulse surveys with their staff quarterly to look at engagement and morale, to try and pick up where the dark spots are, where are things not going well, in order that they can intervene to provide support and help those parts of the organisation function more effectively. Where they do identify, if you like, dark spots that are not working so well, they then do weekly surveys to monitor the progress that they're making towards becoming a healthy, effective team. So I think there's an organisation-wide strategy that you can use, and it's worth also talking with the HR and OD department, with Sarah and others to get advice on these things as well. But don't do it on your own. Okay. So, some questions for you to reflect on, and then maybe just reflect and give you an opportunity to have a conversation together for, let's say, 5 minutes or so in relation to those questions, and the same for the people who are streaming this. So, I just want to unpack a little bit more what we mean by compassionate leadership. It's really important to understand it's the 4 behaviours, but it's also about being effective, because we're here to serve the people of North and Mid Hampshire. And so our compassion must be embedded in effective leadership. And how can we understand what that means? I think a really good way of understanding it is a model that was developed by the Centre for Creative Leadership. It's a big American not-for-profit organisation that works in many countries doing pro bono work, and they came up 25, 30 years ago, Cindy McCauley and Linfit Cooper, with a model of effectively, you have effective leadership in a team or a department or an organisation when there is direction, alignment and commitment. And direction means we have a clear vision, and that's enacted in a limited number of clear, agreed, challenging goals. So let me just be clear, first of all, when we talk about a vision, people often kind of think, oh, all these visions and these. But there is something really important about really continually reconnecting with our purpose in our teams and organizations. You know, making sure that every interaction with patients we're providing the best possible. And in our teams, making sure that we're coming back to what our core purpose is. Why? Because it gives meaning to people in their lives. If I feel the work I'm doing every day is making a real difference to people's lives and their health and their happiness and the communities I serve, if I'm connecting with that, whether I work in the finance department or estates or award shift or maternity, if I'm connecting, if I'm continually reconnecting with that sense of what we're here for, then it gives me a real sense of meaning, and it also builds a sense of engagement. You know, one of the important things about compassion as part of the culture is that we know that when staff feel that their organizations embody the value that they have in their work, then people are much more engaged. So we know from our work over the last 40 years that there is a virtually universal commitment amongst healthcare staff to deliver high quality, compassionate care. And when they feel that their organizations are truly committed to delivering high quality, compassionate care for patients, that's what the core purpose is, the vision is, then there is a match and engagement is much higher. People feel proud of their organizations, they'll go the extra mile, etc. So continually reminding ourselves of what we're here to do and what we're trying to do is important for leaders to make sure that they're continually coming back to that. It's like an anchor point. It's bringing us back again. This is what we're here for. But it's also then about translating that into 5 or 6 clear goals at every level. And I can't emphasize enough how important it is. So over the last 40 years, we've studied healthcare teams, whether it's executive teams or community mental health teams or primary healthcare teams or breast cancer care teams. And the axiomatic finding from all of that work is the most important factor determining the effectiveness of healthcare teams, and this is true in other sectors, is whether they have clear, agreed, challenging goals. 5 or 6 maximum, not 56. It's the most important factor in team effectiveness, or departmental effectiveness, or organisation effectiveness. So does the organisation have a clear vision? Have we translated that in strategy to 5 you have, into, I think it's 6 strategic goals you have in Hampshire, and then every team having 5 or 6 goals, one of which, by the way, should always be improving the effectiveness with which we work with other teams and departments in the organisation. That should always be a goal of every team. So that's so important, and you know that we have those goals. Whether it's the ward shift at the beginning of the shift, okay, what are the 5 or 6 priorities today? What do we really need to focus on? Or whether it's the executive team with its strategy, having 5 or 6 goals. And yet what we see in practice is teams that don't have clear goals, or you see a proliferation of priorities within trusts. There are so many priorities and targets and key performance indicators that no one knows what's important anymore. There are so many priorities that no one knows what's important anymore. How bizarre is that? So, and yet the data tell us, and it's not just from our work, but from international work with teams generally, as well as in healthcare, having agreed what your 5 or 6 goals are, agreed, not having closed, clear, not vague, and please don't be complacent and think that, oh, my team has clear goals. The majority of teams that we look at haven't agreed their goals. I know you're doing work with the FINA here in Hampshire hospitals, and they will help in that process of ensuring that there are clear goals. And it isn't easy agreeing the goals of our team. It's hard work. It should be. It's important to get right. And they should be challenging, because that's the whole point of goal setting, is that we should be challenging ourselves. And then alignment means that people's work is focused on those goals and that vision, and they're integrating with each other. And that we're using our time to best effect, rather than our efforts being dissipated on getting into departmental conflicts or unnecessary bureaucracy. You know, you talked earlier, Alex, about making use of, if you like, the third stakeholder group is the taxpayers. Are we using our resources effectively? That's about, in our teams, is what we're doing really adding significant value to patient care? Whether it's estates or finance or a ward shift, whatever, we should be asking that question. That's what alignment is about as well, and then commitment is trust and motivation. And then, if leadership is not inclusive, then by definition it's not compassionate. And that inclusivity might be in relation to working with multi-professional groups, people from black and minority ethnic group backgrounds. It might be talking about people with from different countries who we work with, or neurodiversity, or people with different political opinions. It's valuing diversity, because the nature of reality is diversity. Every single human on this planet is unique. Every single human being is unique on the planet. It's the nature of our reality. Our ecosystems are full of diverse stars, are unique, galaxies are unique. And we have to embrace that difference and value it. And we know, again, from all of the research that if you have a diverse team which has clear goals and a positive climate, those teams are much more productive and much more innovative than teams made up of people from very similar backgrounds. So, as leaders, by the way, you know, everybody in this room is a leader. all of you have people you feel more comfortable with, who you lead. You like maybe a little more than some others. Don't you? And we tend to spend more time with the people we like and less with the ones we find a little bit more difficult, or the ones we feel are somehow other, different from us, or have different views. And we tend to attribute the success of the people that we like to their ability, and the success of the others to, well, it was an easy job. And we create, inadvertently, in-groups and out-groups. And people generally know which group they're in. And the more we do that, the less effective we are as leaders. So there is something really important about understanding that attending, understanding, empathizing, and helping is ensuring that we're doing that at least equally with everybody in our teams, and particularly with those who may seem other or difficult or whatever than us. So, as I said earlier, this is not about tweaking, this is about making fundamental changes in how we lead our organizations to be more inclusive. Please.
Sorry.
Don't be sorry.
I had a really eye-opening experience actually with my team recently. We just started the Athena team journey, and I am the bereavement lead. So the very first question that was asked was, who is your priority? Who are you here for? Now we have the team has been established for years and years and years, and I thought, well, that's going to be really easy for me to answer. It was a 50-50 split. We had half of the team saying, well, we're here for the patient. And then the other half of the team went, no, we're here for the relative, because obviously our patients are slightly different. And I thought, it was so enlightening, so that is why half our teams are working so differently, because actually we all have very different views on what our ultimate priority is. After this discussion, realising what our responsibilities were, what the law was, our legislation, once it was agreed that actually our responsibility is here for the patient in their most vulnerable time, we are absolutely there. It really has started to change the way we're thinking and change the processing and what we're doing to be more about the patient, not so much the relative. But I just thought, what a fascinating thing. We've all been doing this job day in, day out for years and years and years. Yet we all think so differently what our ultimate responsibility is in it. And it was just really like one simple question just highlighting how, because we've never had that conversation. We are here for the patient, we are here for the relative, we are our main responsibility. It was just so enlightening to realise that one simple question just made such a difference. Everybody gets in and change the way they look at it. So it's just changed the way everyone kind of now leads the team and understand how everybody is now on that same page. I do think a simple questions that we think are so obvious that everybody thinks the same way.
Yeah, and I think it's a brilliant example, and I think that when we start to have conversations about what's our purpose as a team, and what should be our priorities, what should be our objectives, our goals, 5 or 6 of them rather than everything, that it begins to surface those assumptions that otherwise are hidden. And that, as you say, is why it's so important, because then we can have the discussion. It's not dangerous, it's not bad. It's an opportunity to have a discussion and understand and have a richer appreciation of the nature of the work that you're doing and how you can be effective. But if we're all working with a different assumption about who's the priority here, then we can be working at cross purposes rather than working as a really effective team. And I guess the other kind of reflection on what you said about powerful example is how it is important to have time together to talk about these issues, rather than just spinning the hamster wheel the whole time. And what we started looking back in the 1990s at because we saw so many healthcare teams under huge pressure, just spinning the hamster wheel, just busy, 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 busy. And we asked the question, well, what happens if they stop? Take time out and reflect. What are we trying to achieve? How are we going about it? What do we need to change? And what we found and others have found is that teams that do that are dramatically more innovative and productive than teams that don't. one meta-analysis combining the data from 49 separate studies showed that teams that have regular debriefs, time out to reflect, are on average between 35 and 40% more productive. That's a huge win. And I know that on the affinity journey they talk about reflexivity and how we need to build this thing. But just be, we get caught up in just spinning rounds to you rather than taking time out. Days like today, when you can come together and have conversations are really important for connection, for shared understanding, for building relationships. But we know that stopping and having debriefs and reviewing makes such a difference to productivity. This is evidence-based practice. Thank you. So inclusivity and collective leadership. And as I mentioned, we in the health service got probably the most hierarchical, target-driven culture in the whole of industry. It makes no sense because we've got the largest, most skilled and most motivated workforce. Where else in industry would you find 1.4 million people who are universally, that their central commitment is to delivering high quality, continually improving care? It's such an incredible commitment and motivation, and our job as leaders is just to enable that. Let that really be released. And rather than having all these layers of hierarchy which suppress innovation, we have to release that pent-up innovation to staff. And I think the best way we can do that is through building more effective teamwork. As I said earlier, we've got huge room for improvement in building effective teamwork. And the best organisations like Northumbria and now you with the Affinity Team Journey, Merseycare, Royal Bournemouth and Christchurch have been on that journey of building team working for some time. And I'll give you some tips about what that looks like in a moment. So we have to move away from hierarchy towards more. Remember what I said at the beginning? The most important factor in determining the performance of trusts is the involvement of staff in decision making. It's the same. Continually, this message is coming out. That's how we have to transform the culture. And then it's about, as I said, how we work across boundaries. So our compassion is also about how we work with other teams and other departments. And now as we work increasingly across the system with other parts of the system. So we should always be having contact with teams we work with regularly or departments we work with regularly and asking, how can I help? How can we help you so that together we deliver more effectively for the patients we serve? So it's attending to the other team or department, seeking an understanding of the challenges they face, empathizing with them and asking, how can we help you? So that together we deliver more effectively. As I said, I think that one of the 5 or 6 goals of every team and department in the trust should be improving the effectiveness with which we work with other teams and departments. And that's about, going to them. What we know about working across boundaries and building relationships across boundaries is the most important factor by far from the research over the last 75 years in economics and psychology is contact. You have to have contact across boundaries to build relationships. And then it's asking the question, how can we help you? So it should be one of the goals of every team and department. And it means going and having a conversation on a regular basis. Look, we have to work together, whether it's HR working with a department or 2 wards that need to work together, or A&E and the wards that are managing beds. It's having a conversation on a regular basis. Look, how are we doing in working with you? Are we timely? Are we cooperative enough? Are we helpful enough? What can we change that will help you? It's having the contact and the conversation on a regular basis, every 3 months or something like that. So, yeah. I'm sorry, the slides have kind of lost something in transition, but we can manage. It's fine. I was saying to, I think it was Sarah earlier, that you have to be able to manage without the technology if necessary. But we've created a program, cultural leadership program, which about 80 trusts have been through. practical tools for how we can develop leadership. By the way, if you want a compassionate leadership program for Hampshire, I've been working with Wales, NHS Wales over the last 4 years. We've developed a 2-day program which you can have. The program, the PowerPoints, the exercises, the resources, the videos, everything. It's all available for free. This program we created, as you can see, it's emphasizing the areas that I talked about today, and about 80 trusts have been through the program. We know when we go through it that patient satisfaction, staff experience, staff engagement improves, financial performance improves, and so on. So lots of practical resources available for you. Martin, your chair is here. He's also the chair of Berkshire Health. Berkshire Health has been retraining all of its staff in compassionate leadership over the last 5 or 6 years, I think. It now has, I think, the best scores on staff engagement, the lowest levels of stress of any mental health and learning disability trust in the country. We can do this. We can do it. It's having the courage to persist with the strategy that the evidence tells us will work. There are lots of examples of places that are offering courses around compassionate leadership. In Wales, as I said, there is a 10-year strategy to develop compassionate leadership across the whole of health and social care. And what we've done is to articulate the underlying leadership principles. We've talked about them all this morning: collective leadership, direction, alignment, and commitment, improving equality and removing barriers and boundaries. And we've developed a training program. Wales has also come up with a compassionate leadership pledge. This is the pledge that Health Education Improvement Wales has developed. All of the NHS trusts and boards in Wales have signed this pledge and are also now detailing how they're going to put all of this into practice. I was in Ireland a few weeks ago, and Irish Home Care, the biggest social care organisation in Ireland, signed the pledge, and they're moving forward with implementing it. Southwest region, Southern Ireland has committed to the pledge, and the Health Services Executive. Places in Denmark are signing it. You can sign it at individual level, or at team level, or at organisation level. And it's all free, and you get access to resources. We've located the resources on the Global Compassion Coalition website and the pledge that you can sign, which I'll show you in a moment. In Wales, they've recognised that changing the culture of an organisation, it's not just about having a compassionate leadership program, it's making sure that we're building this approach into the DNA of the whole organisation, which is what we've tried to do through this program that I mentioned. So in Wales, what they're doing is ensuring that they have a compassion underpinning the succession strategy, there's compassionate team working, compassionate leadership, compassionate cultures. The staff survey now incorporates measures of compassionate leadership and culture, as we have in the English National Staff Survey as well. So it's making sure we're doing this on a comprehensive basis, building it in, so that we truly transform the culture. In Wales, we have the added advantage that Welsh Government is committed to this strategy and is committed to signing the pledge as well. So that there's an emerging, if you like, strategy of developing compassionate Wales. So Wales is leading in many ways. Their legislation, they passed an act in 2016 in the Senate, the Future Generations Act, saying that whatever legislation we pass has to protect the well-being of future generations. And so the idea of compassionate Wales, building a culture across the whole country in education, in healthcare, in politics, and so on, is gathering momentum, and also in the Republic of Ireland. We can do this. We can do this. We have to get all of the national bodies in England as well, and the politicians. And there are now 100 MPs in Westminster who have committed to developing a programme of compassion in politics in Westminster. soon will take over the United States as well. So the Global Compassion Coalition was formed 2 years ago to try to help develop compassion in all areas of society. It has now, I think, in 2 years, 150,000 members. It's free to join. You get lots of access to resources. And we have a particular focus within the coalition as well on healthcare and colleagues in this country, Wales, Scotland, Northern Ireland, the Republic of Ireland, Denmark, Netherlands are working together to create a coalition of nations focused on developing even more compassion in healthcare. So there's lots of support available. Now, I talked at the beginning about stress, and I want to come back to the issue of burnout and stress to talk about what we can do about this. Most organisations in the NHS focus on what we call tertiary and secondary interventions to deal with staff stress. So, as you can see, things like health and well-being programs or employee counselling programs. Much less used are what we call primary interventions, so changing the workplace factors that cause stress, workload, poor team working, poor supervision, and so on. And yet, what we know is that the most effective interventions are primary interventions. But they're the least used. So I'm not saying we shouldn't be doing these things, they're great. I've practiced meditation all my adult life, and it's hugely important in my life, and I think for many other people as well. But it's not; those sorts of things are not the solution to the problems of staff stress and burnout. They help people cope, maybe, but they're not the solution. So, what are the solutions? Well, as I said earlier, it's our failure to meet the core human needs of staff that is causing staff stress. So 2 national inquiries that I've had the privilege of reviewing, one from the General Medical Council and one from the Royal College of Nursing, into staff health and well-being and stress, shows us we are failing to meet these 3 core needs that we have. A need for autonomy and control. We need to feel in control of our lives. We need to feel that our voices are heard. We're not just cogs in the machine. We need to feel like we belong in our teams and organizations. We need to feel valued and respected and supported. And we need to feel effective in what we do. We need to feel that what we do really makes a difference. And from those inquiries, we identified 8 areas of action. We need to ensure that there is real empowerment and influence. And I've talked a lot about that today. How do we ensure that everybody feels that their voice is heard, that we can really, when we've got an idea for something that's really going to make a positive difference, that we can make it happen. We need to empower people. We need to hear staff voices. You know, I mentioned Northumbria. The strategy that they've used has been extraordinary. So they've committed over the last 14 years or so to really focusing on patient experience and staff experience. I mentioned that they do 4 surveys a year in addition to the national staff survey, and weekly surveys in departments that are in difficulty. They have, between September and December last year, they had 10,500 patient conversations where they gather data from patients. So they also send patients after they've left hospital, patients obviously, 2 weeks after they left hospital, when they're likely to be at their most negative about the experience in hospital, they send them a survey to get them to rate their experience. It doesn't cost anything very much. It's done by text. It costs 3 pence a text. They gather huge amounts of information, 10 areas that they've identified as critical to patient safety. They have semi-structured interviews with patients in hospital done by teams, and they have something like 1,000 conversations directly with patients every month. And the purpose is to feed back the data from patient experience to the relevant ward or department the same day. It goes back the same day. Your patients are saying that pain management was not so good today, or your patients said that staff on the night shift were really lovely. so that people can do something about it. And they've moved that whole program now into Newcastle University hospitals, and they're finding that as they're rolling it out to particular wards, all of the other wards and departments say, we want this too, we want this feedback from our patients, because everybody wants to deliver high quality, compassionate care. Do you know, I said earlier, leadership is about helping people do their jobs more effectively, right? Helping to provide the resources they need. Patient feedback of that kind, that quick, that detailed, is hugely helpful to staff. We can do this because we've got places that are doing this. We can bring it in. I'm sure, I know you're doing lots of wonderful things in Hampshire, and maybe you're doing something as brilliant or more brilliant than what we're doing in Northumbria. But we should be beating a path to the doors of all of these organisations and saying, okay, what can we do? But we get so kind of busy in here, that we don't look at what we can actually do. So, I talked already about justice and fairness and ability care, and Myron Devon and many others are now adopting the restorative culture approach that remember I talked about ability care earlier? So many others are adopting that approach and eliminating unnecessary disciplinaries and suspensions. But we've got to do it, we've got to make it real and authentic. We've got to transform the culture for real, not just having another policy where we tick a box and say, oh, well, we've done that. It's got to permeate the organisation. And it's also about creating the right working conditions for people. People working in horrible spaces. When we talked to registrars in training, we heard such awful stories about the conditions that they were working in. I mean, really dreadful. There is a duvet in the room. It's been there for, a couple of years. It's pretty rocky now. There's also broken computers in the room and broken chairs, and just think, is this how we treat people? So making working conditions good and helping people help control over shifts and rotas, because balancing our own work lives is a key factor in staff stress. If you have young children, or if you're a carer for an elderly patient, you need to have some influence over shifts and rotas.
Hi.
What's your name?
It's Lizzie.
Hi, Lizzie.
I work in mental health. My question is it possible to be too compassionate? Because I think I'm very compassionate to patients, but I know I could be more compassionate to colleagues sometimes. And two things that get in the way of that. One is my personality. And the main thing is the fear that you can get taken advantage of or mocked off in some way. What do you think about that?
I think that one of the things we tend to do is put people in leadership positions without giving them adequate training. And what that does is leads people to feel quite anxious in their leadership. So I see lots of people. So okay, I thought it was celestial. Do you need to take it? It's fine. So we put people in leadership positions in the NHS without giving them adequate training. I remember talking to a general in the army, in medical services in the army, and he was telling me he'd been 35 years in the army, and 22 of those years he'd been having training. And there's a real ongoing commitment to training people. What we tend to, I think there's a danger of saying, well, we've got people in a leadership training course, and that's it, leadership training is done. But actually, leadership is a continual journey of learning. And I think if we're not confident in our leadership, then we're more likely to feel that we could be taken advantage of, or that we've got to use a command and control style, because we don't feel that, we don't recognise that the humility in leadership that you talked about there is part of saying, well, yeah, I don't know, I'm not sure, what do you think? I mean, that doesn't apply in all situations. I'm having open heart surgery and I start a hemorrhage, I don't want the surgeon to pass pass out post-it notes. Yes. But we do want leaders to be comfortable in enabling their teams to lead, rather than the leader feeling like he or she has to, which I think is a mistake when you have such motivated, highly skilled people. It's how we enable those we lead to be empowered. And I'm sure your personality is wonderful. Thank you for the question. Really helpful. And then team working, I'll talk a little bit more about culture and leadership. We've talked about the example from Berkshire Health, I think is a fantastic example. I've talked a little bit about workload, East London Foundation Trust, good management and supervision. We talked about that and about how we need to ensure that people are continuing to have opportunities to learn and grow. It's a key factor in staff retention. When people have got opportunities to continue to learn and grow, then we retain staff much more effectively. So the point I want to make is really fundamental here, is that dealing with burnout and staff stress means really focusing on these 8 areas. So when we're at board level, executive level, departmental level, how are we doing in relation to these 8 areas? What do we need to improve? And by the way, all of these 3, these 2, and the bottom 2 are like resources. So the more you can get these things right, the better. They don't cost anything by and large. This one is a demand. And we know that the more you get these 7 right, the better are people able to cope with that. I'm not saying that, you don't need to worry about that then. I'm not saying that. But I am saying there's hope in that if you get these other things right, then you massively help people cope with your workload. It goes back to the question that Zena asked earlier. Is Zena still here?
I'm leaving.
Stupid meetings. So, just you can reflect on that. I want to talk about team working, and I've said a lot about this. We can think about compassionate team working at 4 levels. How compassionate team members are to themselves. One of the things I think we need to do within our teams is start talking about self-compassion, raising awareness about the importance of self-compassion in our teams. From every team in the organisation, let's talk about this. Part of our responsibility as a team member is to be self-compassionate. So we need to give people within our teams the resources to learn about self-compassion as a life skill. And I'll say a bit more in a moment about it, so that we start to raise awareness of that. And it's about then how we work as team members in terms of how compassionate we are to each other, how we work as a whole team in terms of our compassion, and how we work across boundaries in terms of our compassion. So, from all of the work that we've done over the years, and Athena OD has done as well, but the data that we've gathered over the last 40 years from healthcare teams, we know what the key features are of effective multidisciplinary teams, whether it's an executive team, ward team, breast cancer care team. These are the features. If you take this slide, and Sarah, we will circulate the slides to everybody and the people who are streaming in. You can take this slide, you sit down with your team in the next few weeks and have a conversation as you described. I didn't catch your name, sorry. Kirsty. As Kirsty described, you have a conversation with your team and you discuss these questions on the right. And what we know is your teamwork will radically improve. And you do it again in another 3 months, 4 months, 6 months, it'll improve again. And you keep having that conversation. And your first reaction may be, we can't waste time doing that. Go back to the data that I showed you about how important teamworking is to stress levels, error rates, violence, patient satisfaction, care quality, avoidable patient mortality. we've got to get teamwork in right. It's not difficult. It's what we've done for hundreds of thousands of years as a species, but we're doing it badly within our organisation. So we've got to get these things right. You know, things like regular, positive, engaging team meetings. We should be at the end of every meeting that we have. We should be spending 5 minutes reviewing. Did we need this meeting? Was it useful? Were we all engaged? If you've got 8 people in a meeting for an hour, that's a day's work gone. Is it worth a day? Is this a day's work? Is it worth it? So taking that 5 minutes at the end of every meeting and reviewing, did we need to be all of us in this meeting? Did it need to be an hour? Were we talking about the right things? Is the outcome useful? If you count up the amount of time and the cost of all of these meetings we have, we've got to get them right. We've got to make them worthwhile. So sitting and asking these questions within the team, discussing them, you will improve your teamwork. Any questions? All make sense on there? I'm sure it's clear to you in the sense, yeah, you know all of this, but it's making sure we're getting it right. Making sure that all team members are involved in the important decisions which affect the team's work, for example. Any questions? Please.
What do you
Tell me your name.
Sorry, Colin.
Colin, hi.
What do you do if you do have team members who aren't engaging? And no matter what you try to do, you try to open out and get people in your team to be part of the team and to ask them for their engagement and be involved in the decision. Sometimes team members do drop out, and is there a way to try and build that engagement back and reinvigorate the engagement within the team?
So I think it's really important to have the conversation about what our vision is, what our purpose is, what our core purpose is with the whole team, because that's a very important way of engaging people. It's really important to have the conversation about what our goals are and to ensure everyone is contributing, because one of the characteristics of effective team is clear, agreed, challenging goals. So they have to be agreed and shared. So if people are not participating, then by definition the goal is not shared. So we need to involve everybody in that. You know, one of the things you can do in meetings is bring people in. So Colin, I know you've got some expertise in this area. What are your thoughts about that? And you can also have individual conversations with team members. You know, you can feed back and say, look, I'm aware that you don't really contribute much in the meetings, or that you seem to have kind of disengaged a bit. What's going on for you? How do things feel for you? So you use the skills of attending, understanding, empathizing, and helping to try to understand what's going on for them. Because one of the mistakes we make in psychology, it's called a fundamental attribution error. A bit of jargon, it makes it sound really impressive. All it's saying is that we attribute people's behavior generally to their personalities rather than the situation they find themselves in. But behaviour is usually a result of the situation we're in, not a personality. So trying to understand their situation is the beginning point, and that's why those 4 behaviours are so important. Yeah.
Hi, Michael, my name's Amy. I've just done this with my team, and we had a meeting this week actually to discuss the findings, and one thing that I didn't expect to come from it was like opening a can of worms, and that's what I wrote in my kind of looking back at it. I think one of the things that I didn't consider before doing it was the maturity of the team and also my role in it as a facilitator, and I needed to consider that really clearly whilst I was going through that, and there was a lot of thoughts going through my head, and I don't know if you could recommend anything going forward on this journey of how we can prepare ourselves for such conversations that happen.
So when you start to have the conversation, what it reveals is a lot of unhappiness and conflict that you weren't prepared for.
Yes.
Yeah. Yeah. Presumably that was something experienced by quite a few members of the team as well.
Conflicting conversations, to be honest.
Yeah. Yeah. It is interesting. One of the I suppose learnings we've had from looking at teams over the years is that people tend to like you have a survey in a team, so we'll survey our team and you look at the average scores. And what that masks is disagreement. And so we come to see disagreements about views of the team. We come to view those as important as the average scores. Because you may have a number of people saying, oh, this is pretty good, but you've got 2 or 3 people who will say, no, this is not good at all. The average score is good, but the disagreement is there and needs to be surfaced and discussed. But we need to create ground rules within teams about those discussions. So the starting point probably to have this discussion is to agree what the appropriate ground rules are: confidentiality, mutual respect, supportiveness, and creating not just a psychological safe environment, not just creating psychological safety, but safeness as well. So Paul Gilbert talks about how in a team you can create an environment where there is psychological safety. We feel safe to give an opinion and not to be ridiculed or humiliated. But more than that, we also need safeness, where people behave caringly and lovingly and supportively towards each other. Because you need safeness as well as safety. Safety is freedom from threat. Safety is creating that loving environment, compassionate environment, if you like. So probably there's something about creating those ensuring those kind of agreements around ground rules to begin with. But if you'd like to discuss more about it, then get in touch with my email is on the last slide. Get in touch with me. And we can talk some
You
more.
might regret that.
Any other questions?
Mine is actually not a question, but to share a view. I learned something from one of my very good teacher from a program I went to on advanced communication. And she said something about we as health workers generally, but leaders and in other areas, we are always going towards the quest of fixing and not listening. So then the problem comes by we just fix, but we don't know if you are fixing the right thing or fixing the wrong thing. You don't want to give the audience to people you are leading. You don't want to listen to what they have to say. Even as health workers, you don't want to listen to your patient. You don't want to pick those cues that they show you by just mere listening to them. And she said something, sometimes don't fix, just listen.
Yeah.
Don't be in a rush to say, okay, this is what we have to do, and then you come back doing it not in the way it should be done, or you do it something totally different, and you have not solved the problem because you failed to listen. I think that's one of the reasons why some members of team give up on their leaders.
Yeah.
Because they get frustrated of, say, after maybe having series of meetings, like you will say useless meetings, series of meetings, you go for meetings, and the outcome remains the same. And then tomorrow your leader will come to you and say, oh, there's this one coming up, what do you think? You will not have anything to think, because you will end up saying that it still remains the same, because the leader already had what she thinks in her mind, or what he has already set to bring about. It's just like, so that they will not say, I didn't ask my people, I've asked them, but you already have what you want to produce. So I think our leaders, they should have this audit or an avenue to listen more than fixing. Because when you listen properly and listen attentively, you fix better than rushing to fix without listening.
Could you come up and do the talk? Listening with fascination is not about jumping in with hips and listening deeply, listening with your heart as well as your head. And it's about involving people in decision making. Through listening, we can help people be involved in decision making. And it's right to say, you know, compassion is not about helping, it's not about fixing problems necessarily. It's about listening and understanding and empathizing, as you said. And in that process, people often generally come up with their own ways forward. So, it's the second point here, isn't it? Being present and calm in the face of suffering without needing to fix necessarily. And as you say, we often end up, when we're not really listening, we jump to conclusions about what the problem is and then come up with a solution to the wrong problem, so it's not a solution at all. But it's practicing compassion in our interactions in our teams. It's putting this into practice in our teams. So that all of us having the courage to challenge policies within the organisation oriented to blame and addressing corrosive politics and toxic interaction and underperformance. So it's all our responsibility to address these issues. And I've said in relation to teamwork already, taking time out on a regular basis to review what are we trying to achieve, how are we going to battle it, what do we need to change is hugely important to productivity. Remember the figure I said? Between 35 and 40% greater productivity because of all of the innovation. So, and yeah, this is just some of the latest research evidence on teamwork. We've known for years that having clear goals is crucial. We know that team empowerment is more powerful than just empowering individuals, and shared leadership in teams predicts team effectiveness. We know this stuff. We know it, but it's putting it into practice in our organizations. So there's so much we can do by just getting team working right. It doesn't cost anything, but it is a radical change, and that has to be the future. So, yeah, that's a summary of what I've been talking about. I'm not going to go through it. It's and you can find a lot of this in the book. I only had room for 3 books in my suitcase, and there's only 2 left, because I was privileged to give one to Venus. So if anyone wants a copy, then there are 2 there. But I want to finish by talking about the importance of self-compassion. It's the final chapter in the book, and I think it's the most important. I've come to understand it's the most important chapter. Because as people working in healthcare, I think the danger is that you're so focused on delivering, on being compassionate to others, that we neglect to be compassionate to ourselves. And actually, I think it's generally true in humanity. We haven't developed enough capacity to be self-compassionate. And this is not about some narcissistic self-indulgence. This is about being compassionate to ourselves in order that we can be compassionate. In order that we have compassion for others, we can have compassion for others. And I really want to talk about it at 3 levels. The first is managing ourselves in terms of recovery from the very challenging, demanding work that we do. Sabina Somontar, professor at Mannheim University, has been studying this for years, and her research and others shows that we recover when we engage in activities that enable us to detach from our work. So having a meal with friends, watching a Netflix series, whatever it is, engaging in activities that challenge us outside work. I got sick with COVID 3 years ago and started building on my GCSE level French on Duolingo. So I do that in the evenings, and it's kind of enjoyable. It helps you disengage from work, relaxation, meditation, having control outside work about what we do, not just another long list of tasks to get through. So choosing what we're going to do. Taking proper work breaks, we know, is important not only for recovery, but for safe patient care if you have patient contact. Taking proper work breaks is important for recovery, but also for safe patient care. We make more mistakes when we haven't taken our lunch breaks or work breaks. There's some great work from the Mayo Clinic showing that when doctors have lunch together, patient care is much safer, dramatically fewer errors. And we know now about the huge impact of nature on recovery, being in nature on our recovery. So it's extraordinary how powerful being in nature is for us. And there's a kind of hierarchy of effects, with blue spaces the most powerful. So being by lakes or rivers or the sea, we recover most. This is well, you can't see it, but it's a picture of a reservoir about 4 miles from my house that I cycle around. Beautiful. And then come green spaces, the hills, the forests, the countryside, and then urban green spaces next. But even being outside at all helps. And the more biodiverse a space we're in, animals, trees, plants, insects, butterflies, birds, the more we recover. Extraordinary, amazing. And we also know that the people who most need to do these things are least likely to do them. By the way, that applies to occupational health and well-being problems as well. But the people who most need these well-being programs are least likely to take them up. So raising awareness about looking after ourselves in this way is part of being self-compassionate. And we know from research on the ways to well-being that the most important is belonging, spending good quality time with the people we love and who love us. The copy of the slides that you will all get it'll have everything on them. Yeah. It's sometimes different versions of PowerPoint that end up chewing it up, but you'll all have all of the material on all of the slides. So probably the most important factor in our well-being is spending good quality time with the people we love and who love us. And then it's things like being present in the here and now, exercise, of course, getting enough sleep. The function of sleep is repair and maintenance of body and brain. And generally we need 8 or 9 hours on average. Most people are taking, on average, 7 hours sleep a night. And you can't cheat nature. There will be health consequences and cognitive function consequences. And it's also about continuing to learn and grow. That's part of what contributes to our health and well-being, and helping other people is really critical as well. So belonging, exercise, sleep, being present in the here and now, helping others, continuing to learn and grow. But the deepest level of self-compassion, what's on the slide. This is a book by Tara Brach, but she has an acronym. There are a couple of people you can look up. Kristin Neff writes a lot about self-compassion, provides lots of training on self-compassion. Tara Brach. And the Global Compassion Coalition I mentioned earlier has lots of material. And Compassionate Mind Foundation also provides lots of material on self-compassion. The deepest level of self-compassion is having the courage to be present with ourselves, to be aware of myself. So that I can recognize when I'm feeling bad, when I'm feeling angry, hurt, ashamed, overwhelmed, exhausted, irritable. And then the acronym is RAIN that Tara Brach uses: recognizing, accepting, inquiring, nurturing. Recognizing, through being present with myself, recognizing when I'm feeling bad. And being curious about that. Oh, why am I feeling bad? What's this about? You know, we're so often caught up in feeling bad, we don't even notice it. Oh, it's such a familiar feeling, feeling inadequate or feeling hurt, or we just don't notice it because we're so used to it. So it's about having the courage to be present with ourselves and to know when we're feeling bad and to inquire into it. Why am I feeling like this? I just had that really unpleasant conversation. And having the courage to accept what we're feeling rather than push it away or deny it. Because the more we push away these things, the more we disconnect from ourselves, and the more difficult it is then to connect with others. And so when we accept our feelings and have inquired into them, then we have a choice. We can care for ourselves. You know, Martin in Berkshire, the training program that Deborah Lee leads there, I know you ask your staff at the beginning of the training, who's the person you've had the longest, deepest relationship with in your life? They ask them to answer that question. And then they say, well, actually, whoever you've chosen, it's you. And they say, how's that relationship going? How kind is that person? How caring? How compassionate? How much fun is that person? So self-compassion is about turning that nurturing on ourselves. In the Stanford Compassion Program, they have 3 questions. When you're feeling bad, ask yourself, what am I feeling? What do I need? How can I get that need met? If you have a dear friend or a colleague who's upset, what would you do? You'd want to help them. You'd want to nurture them. Like that film at the beginning. Well, why wouldn't we do that to ourselves? After all, each of us is as deserving of love as every other human being. So all of this begins with having the courage to be self-compassionate. And when we connect, and this is not just a leadership skill, this is a life skill. This is a life skill. And when we connect more, when we have the courage to connect more deeply and authentically and courageously with ourselves, then we know it enables us to connect more deeply and compassionately and caringly and courageously and authentically with all of those we provide care to, and all of those we need, and actually with all of those we interact with in our lives. So all of this begins with having the courage to be self-compassionate. So, thank you very much for the privilege of sharing all of this with you. Wonderful opportunity for me. There's my email address. Thank you for all you do in your work, and thank you for listening to the presentation.